I'd like to introduce our first speaker this morning. Many of you have known this gentleman for quite a while, and if not, you will meet him today. Dr. Ben Park. He is the Director of Precision Oncology at Vanderbilt Ingram Cancer Center. Dr. Ben, take it away.
Oh, thanks, Al. Hey, it's great to see familiar faces and new faces, and this is really an honor to be leading off on Saturday. And thanks again for the opportunity. I'll try to keep this short. I was asked to just kind of give some updates on research, and so that was an opportune moment to actually share some of what we've been doing at Vanderbilt, and I'm going to share this screen right now. And let's go to, can you all see my screen okay?
Yes, we can.
Okay, perfect. So I'm going to talk a little bit about updates of how we actually interpret Oncotype DX, which many of you probably heard about for male breast cancer. This has been a little bit of a conundrum in our field because male breast cancer, as we all know, is fairly rare. And we also know that most of the clinical validation in terms of what Oncotype is and what it does has been done in exclusively the female population. So with that, I'll give a little bit of background and where we are in terms of the field and where we're going for male breast cancer. These are some of my disclosures. Now, for those of you who aren't familiar with what Oncotype DX is, this is a really important area, or it was at least in the past 2 decades, where we recognize as medical oncologists. So I'm a breast medical oncologist. I treat patients with chemotherapy, hormone therapies, and sometimes HER2-directed therapies like Herceptin. And what our job is for early stage breast cancers to figure out who's going to really benefit from getting additional systemic therapies. Our problem with breast cancer, like many solid tumors, is that it's a local disease, and that's in the breast and the lymph nodes in the armpit. And that's why they get taken out by surgery, and then sometimes radiation kind of sterilizes that and is needed for certain use indications, we call it. But then we have to make the decisions as medical oncologists. Who do we think likely has microscopic cancer cells floating in their body that's going to come back as incurable metastatic disease in the future? Because we know through clinical trials that if we treat everyone, we can reduce that recurrence rate, meaning that we're actually curing more people. It's not perfect. We cure maybe 50% more people than that would have otherwise recurred. But across the spectrum of all breast cancers, female and female, we know we're doing much more good than harm. At the same time, we've recognized that chemotherapy and other therapies can have sometimes permanent side effects. And so this is something that we've been doing as a field now for the last decade, what we call de-escalating therapies. So who's going to really benefit most and who's really just going to get toxicity and not need it? Oncotype was developed in the early 2000s to address this question. It's a pretty simple assay by today's standard. We just take the tumor out. We do what we call an RT-PCR for expression of 21 genes. And this has been validated as both what we call a prognostic tool, and then I'll show you a little bit what I mean by a predictive tool. But there's a whole score from 0 to 100 that tells us, and I'm being purposeful by saying women, because again, there's not really validation as much in men or male breast cancers, but it actually tells us what is the likelihood of recurrence at 5 and then 10 years. And we kind of lump it into 3 big buckets, even though there's a score from 0 to 100 of low risk, intermediate risk, and high risk. This is really only applicable for patients who have estrogen receptor positive disease that is currently node negative. There is a node positive study going on that I'll mention, and also HER2 negative. All right, as I was alluding to, prognosis is not the same as predictive in terms of our lexicon in breast cancer and chemotherapy in general. Prognosis is what I was saying to you earlier. What is the likelihood someone's going to recur at 5 to 10 years? Predictive in our language means what is the chance that there's going to be a response to chemotherapy or any therapy? And those are separate because even though something could be prognostic, let's say there's a 10% risk of recurrence at 10 years, if we don't have a way to modify that risk, then we can't do anything about it. Prediction means that if we gave chemotherapy, do we actually reduce that risk? Do we actually cure more patients? And so again, those are 2 separate buckets, but obviously related. We know that retrospective data when Oncotype first came out suggested that Oncotype was both prognostic and predictive, but it really took a randomized, blinded prospective trial of multiple institutions, which takes years, if not decades, for follow-up, because literally we just have to wait and see how many women are recurring who got chemotherapy for a given score versus those who got placebo. And that study was done, and results were reported a couple of years ago now, and definitively show that Oncotype, the trial was called TAILORx, is predictive as well as prognostic. Now, it was mostly postmenopausal women that we actually now know if they get an intermediate risk recurrence score, because we kind of already knew that low risk women do not benefit from chemotherapy, high risk women do, but most patients fall into this big intermediate risk category. And now with the results of this, it really shows that, again, even though it's prognostic, a high intermediate risk has a higher likelihood of recurrence than a lower intermediate risk. But chemotherapy does not modify that. So it's predictive in a negative way, meaning that we now spare women, many women who are postmenopausal, from getting chemotherapy. Probably the estimates are upwards of 70%. Premenopausal women in this analysis or in this trial, we're still in a gray area. So we're still in a little bit of a quandary of what to do for premenopausal women. And that's important when you start thinking about male breast cancer, because the hormonal kind of milieu, if you will, is very different between men, premenopausal women, and postmenopausal women. As I mentioned, there is an ongoing node-positive study called RxBonder, again, in pre and postmenopausal women, but not so much in male breast cancer. So I think male breast cancers were allowed for that study. But that brings to the last bullet point. What about male breast cancer? Well, we started really asking this question and looking at this a number of years ago, and a colleague of mine, Steve Shack, who's actually the first author of this poster that was in 2009 for ASCO, and Steve was actually, I met him at a meeting, and he was actually one of the founders of Genomic Health and this test. And so he shared with me this slide deck, and I'm putting it up here, but again, this has been shown publicly already in ASCO almost over a decade ago. And this is a retrospective analysis. So again, they're just looking at patients who already had this, comparing male breast cancers to female breast cancers. Now, there is no outcome data tied with this. All they were simply doing was looking at these 21 genes and seeing, is there big differences or not? And in fact, it didn't look like there were big differences. There were a few things noted here that were slightly higher on average in male breast cancers versus female, but really there was not these huge, differences, and you can see that from the red versus blue here. Limitations, of course, is that male breast cancer is a smaller population of this study of 347 patients versus the 82,000 in women. But this at least gave us some confidence that we could extrapolate some of the results from Oncotype to our male breast cancer patients. Fast forward now 11 years, we just published a study, and this was really led by my collaborator and colleague here at Vanderbilt, Xiaoyu Xu. Again, this is published in January of 2020 in Clinical Cancer Research. And what we observed and what we did was also a retrospective analysis, but in a much, much bigger patient population. And in fact, there were some disparities observed between male versus female breast cancer when it comes to the Oncotype score. And that's summated here. Oncotype may be different from male breast cancers. So in A and B, you'll see the male breast cancers. And here we had 800 plus male breast cancer patients, and again, I think 20-some thousand in women, and C and D on the right-hand side is in women. The recurrent score buckets, again, if you will, of low risk, intermediate, and high risk are a little bit different on the actual test than what was used for the trial that I mentioned, TAILORx. And that was so that they could capture everyone in a 95% confidence interval. But I think you can see here, when you compare the left curves to the right curves, no matter which recurrence score, that in fact, men who have a higher risk recurrence score relative to women who have the same score, or at least the same category score, do worse. And this is something that we've all suspected, that there is some differences in biology that may lead to breast cancer in men being a little bit more aggressive or having a slightly worse prognosis, or in some cases, even a dramatically worse prognosis. So the conclusion of this is extrapolation of Oncotype DX to men is not perfect. Again, I think we've known that, but this really highlights and underscores that. The limitation of our study really included, again, that it's retrospective, that it's uncontrolled for testing practices. As an example, we don't know exactly if men were tested inappropriately, meaning that they probably shouldn't have been tested if they had more positive nodes than the female counterparts. We have information of chemo, but we don't know what the kind of trigger, if you will, to giving chemo or not was in the male population versus the female population. And so these are all limitations of retrospective analyses. Right? This wasn't a trial that controlled the lanes, if you will, of who gets chemo and who doesn't. And that's why I always consider these types of studies hypothesis generating, not hypothesis proving. Of course, to really get to that level of data, we'd have to do the same type of trial that TAILOR-X was. But given the rarity of male breast cancer and the cost of clinical trials, most of us feel like that would probably not be feasible. But that is really the gold standard of any statistical design to prove that this would actually be the case. But it still leaves us with this question: are we undertreating and perhaps overtreating early stage male breast cancer? And you know, that's what physicians like me really worry about for all patients. But because we don't have as much validated data for Oncotype, that's really the big unmet need. And I think many of you have heard my talks about liquid biopsy and how we might use that to really address this question. And I think probably my 5 minutes are more than over, so I thank you for your time. I will stop sharing, and I'm happy to answer any questions.
Thank you, Dr. Ben. Wonderful information. And who would have any questions? Sherry, go. Does anybody have a question?
My favorite. Leave them speechless.
I actually do. It's Sherry. It's not really, well, it is sort of a question. In yesterday's conference, we had Dr. Susan Love on. And we know from looking at the information back and forth on social media that a lot of our guys have a very different experience with the drug, tamoxifen and what have you. And what we decided to do, and we're going to jump on a phone call with Susan, is that we are going to put something out to the men where we ask them what their experiences have been. And she's actually going to take that information and gather it, and is looking to put it into a study of some sort to, you know, look to see where we could look into helping these guys a little bit more and doing a little bit more in like a research area with it down the line. Would that be something that you would be interested in, the data from that as well?
Absolutely. You know, as a researcher, the more data, the better. And I really applaud the fact that this group has really come together and really started making this aware for the breast cancer community, research community as a whole. And, you know, to that point, I swear I didn't actually plug Cheryl to say this, but we are planning at our institution a big study. We don't know if it's going to get funded, but we actually need men because we're going to be studying rare populations of breast cancer, i.e. male breast cancer, as well as young women less than, I think our cutoff is going to be 39 and lower. But we also, as part of the overall process, and it's actually mandated, which is great, we need to come up with advisors and patients who have been affected or themselves or know someone who's been affected with male breast cancer and young women or early onset breast cancer. So I'm going to just take this forum for, and if you'll indulge me, to reach out to you all that if you have interest in helping us out with this, please let me know. Peggy has my email.
Yes, yeah, and we'll definitely post it, and you just give us whatever, we'll get it going. You know, our men are always open to hopefully getting more research. And Dr. Jay Harness is going to be working with Breast Cancer Answers. They're going to be working on stuff specially for men this year. And we're going to collaborate, so I'd love to bring you into that too, Dr. Ben.
That would be awesome. That's why I emailed you yesterday about the numbers, Peggy, about how many men that you capture in this forum, because this would probably be the largest kind of study of male breast cancer ever. We're trying to hit for something like, you know, hundreds of men so that we can actually get their tumor tissue, get blood samples.
And we're working on that. If you stay on, Dr. Lopa, and then we're going to be talking about some stuff that hit her and Benny are going to be doing that I'm sure we can bring all together. So stay on and listen to that, because I think if nothing else what this virtual conference is doing is bringing more to the forefront through the pandemic, and where our guys really want to be part of any research that you all can think of, so we can help each other. That's what it comes down to doing.
Wonderful. Thank you all.
Yeah, absolutely. All right.
Peggy, can I ask Dr. Park, do I have a minute? Okay. So Dr. Park, thank you so much. And I also wanted to thank you for all the help you have been doing with Breast Cancer Hub, you know, like So I have a question. to the data that you presented, right? Like 2009 versus your study, recent study. So in 2009 data, it's been said that there's not much difference between the male and breast cancer scenario, the expression. But you mentioned that with your study, your group, you see that there is a difference in the biology. So how, I mean, why is this, I mean, just the question is that how different is this, and what different expression do you think, or maybe if you would like to share with me the article, that would be great too. So
Yeah, I just saw in the chat that I will actually put it in the window too for the link. The first study, you have to remember, did not have any clinical outcomes. So the main purpose of that was just to take male breast cancer, female breast cancer, and look at the exact same 21 genes and see how different or not they were. And for the most part, they looked pretty similar. And that I didn't show the full poster, but the partitions of how many percentage got low risk, intermediate, and high were very similar between male and female breast cancer. And yet, if you look at the curves, that's what we did. The curves seem to suggest recurrence score is a different number. So a 21 would be different for a woman than it would be for a man. This to me is not that surprising because the same happened with node positive patients. When Oncotype first came about and there were node positive patients, they applied the same kind of metrics and algorithms. And what they saw was, yes, it was both prognostic and probably predictive. Again, that's why we have this new study going on. It's not quite old, but the recurrence score scale, even though it's 0 to 100, again, a 21 for a node positive patient is different than a 21 for a node negative patient. And so what this is telling us is that, yes, this can measure these 21 genes, but remember, we have 50,000 genes in our bodies, and we're only measuring 21. And so part of this trial and study that we're putting together is to measure all 50,000 genes and to measure everything in our DNA, as well as what we call whole exome, with the idea that can we actually learn more about male breast cancer biology and what is unique about this. You know, we already have clues and hints. If you're going to have a BRCA gene mutation in male breast cancer, it's usually BRCA2. As many of the audience know, most male breast cancer is ER positive, more so than even female breast cancer. So this is actually speaking to us that we know there are inherent biologic differences. That's what we hope to uncover so we can actually treat more precisely, if you will.
thank you so much. Yeah, that's helpful.
Doctor, could I ask a question?
Please.
Yes, this is Tom Anselm speaking from New Jersey. Thank you for being here, Doctor. I'm going to go in a little different direction. It's serious to me, but I was diagnosed with HER2 positive 6 years ago, and I had it removed. I had a mastectomy on my right breast, and I'm doing fantastic. I've been taking tamoxifen now for 5 years, and I've had very few side effects.
Right.
A few mood swings here and there. You can ask my wife, but that's about it. I'm not having hot flashes. I had about 3 or 4 in the 5 years. My question is, recently I developed pain underneath the scar, and I haven't heard this on the coalition, Brett, and I haven't heard anybody ever mention this, but it's hurting. And I went to my oncologist. I had a bone scan, had an x-ray, nothing wrong with the bones, and I'm getting an MRI on Tuesday. My question is, could it be scar tissue? And what does scar tissue feel like? And can you relieve it? Because it's right under the scar. And I had 3 lymph nodes removed, plus the nipples. So it's a pretty long scar. And right underneath that, when I press under there, it's sore. And when I turn, it's sore. Both directions. When I'm sleeping, it's sore. And I'm just curious, could it be scar tissue from the surgery?
It certainly could be. I would actually recommend, because it could be almost anything. Likely it's not recurrence, but it could be. And that's something that we would want to know early rather than later, because local recurrences still have a possibility of cure. And so this is why we actually do breast exams as well as mammograms if there's breast tissue remaining for the first 5 years, because studies have shown if we detect this, we can get it out and cure more patients. So I would, and as medical oncologists, you know, we know these things, but we're not the ones who did the surgery, obviously. So whoever did your surgery, I would definitely contact him or her, make sure that they agree that this could be scar tissue. They may do an ultrasound just to be sure. They may even do a biopsy just to be sure. But I would not, especially if this continues to persist and doesn't go away, I would actually go to your surgeon and make sure that he or she is okay with this.
Thank you, doctor.
Dr. Park, I have a question.
Please.
Ron Rappaport, how are you?
Good. How are you doing, Ron?
Good to see you. I'm good. This recurrence score that you said differs from men and women. Can you give us, for example, if we got a really low score on Oncotype, like a 7 or a 6 or 8, can we feel pretty confident that we didn't need the chemo, or is it up in the air still?
I would actually extrapolate and say I'd feel pretty confident for that. I think where I would take notice and maybe even exception is, again, in this gray area for intermediate risk recurrence score. That's where traditionally we had lack of clarity, and now we have clarity from that trial, but really only for postmenopausal women. And in premenopausal women, we don't actually know what the right thing or the best thing to do is. Some would say give chemotherapy because, they're younger women at risk. Some would say, well, the postmenopausal data would suggest chemotherapy is not going to do much, but what we should try to do is make them postmenopausal and give them what we call ovarian suppression with hormone therapy so that you're mimicking the postmenopausal state. Some would say do both. And I think that that's the challenge with men, is that we don't really know, what is the optimal thing to do in that intermediate risk recurrence score. The data that I just showed you from our institution would suggest that the threshold for giving chemotherapy may be lower because the, again, bucket per bucket comparison would suggest that a lower risk recurrence score is higher risk, relatively speaking. I said that incorrectly. That if you took a 21, that might actually say you might benefit from chemo for men versus not for women.
Okay, thank you.
I've got a quick question. This is Bill.
Yes.
Is there, as you're looking at this data, does it appear that male breast cancer patients are more similar to premenopausal versus postmenopausal women? Is there any trend in terms of that, looking at that?
That is a great question, and we've thought about that too. We unfortunately don't have enough data to really suggest that or understand that. But the conundrum or the problem that we're facing clinically is the same. What do we do with this information? And should we be treating women and men, premenopausal women and men more aggressively with both, some men on here probably have experienced this, but using shots that shut down the testes, just like they're the same shots that shut down the ovaries from hormone production, in addition to tamoxifen, or should we add aromatase inhibitor and or chemo? So I think it is a great question. It's one that we've thought about and struggled with, but it biologically may be the same. And that's kind of also the gist of our big study that we're trying to propose and writing a grant for, why we have women 39 and younger as well as men, so that we can compare and contrast those biologic differences. Great questions.
Thank you.
All right. I am going to stick around, Peggy, for as long as I can.
Thank you. We appreciate it, Dr. Ben.